It's great to have everyone. We have a fantastic session, and I have the privilege of kicking it off. I'm Greg Martin. I'm a pulmonary and critical care physician at Emory University in Atlanta, and the past president for the Society of Critical Care Medicine, the sponsor or the shepherd for this section. Let me introduce my co-chair, Dr. Diaz-Gomez, and then we'll move on and start talking about our next speakers.
Buenas tardes, bienvenidos. Thank you so much for being here. It's such a pleasure moderating this session with Dr. Greg Martin, our past president. Currently, I am part of the SCCN Council, and my background is anesthesia and critical care medicine.
Thank you, Jose. So we have three speakers this evening. They're going to talk about future respiratory medicine challenges, and particularly thinking about health system strain like we've seen over the last couple of years, but also about both protocolized and personalized ways of managing respiratory failure. So our first speaker is Dr. Haley Gershengorn, who's a professor in pulmonary critical care and sleep medicine at the University of Miami, where she works as a medical intensivist. Her research program is really focused on allocation of resources in the ICU, in such that particularly managing or optimizing outcomes for critically ill patients. She's also interested in staffing and practices which may be tied to staffing for optimal outcomes in the ICU. She's the chair of the internal medicine section for the Society of Critical Care Medicine and the chair of the Women in Critical Care group for the American Thoracic Society, and is now newly announced as the inaugural editor-in-chief for the new open access journal, Chest Critical Care. So Haley, let me hand it off to you to talk about our first topic of respiratory failure when resources are strained.
Great. Thank you so much, Dr. Martin, and also Dr. Diaz-Gomez for the invitation. I'm just going to share my slides. Can someone just tell me you guys can see them all right? Perfect. So I get the privilege of kicking off this session, and I'm going to be speaking a bit about managing respiratory failure when resources are strained. So I have just two disclosures. I had served on an advisory panel for COVID therapeutics, but that's over, and I received some grant funding. So in the next 15 minutes or so, I want to try to walk through for you what I mean by resource strain, how I think this strain can affect what we're doing in our ICUs, how we might lessen the impact of strain with particular focus on respiratory failure, and then sort of end us with some sort of cautionary tales of potential downsides associated with solutions to respond to strain. So just as sort of a framework for this brief overview, when we think about strain, I want to talk briefly about space, stuff, and staff. And this is one of the ways that resources can be sort of categorized to help us understand what we have available. So when it comes to space, I think the most notable one, and we've all experienced this over the last several years, relates to literally ICU bed capacity, right? And this is a study from Ed Litton's group from a few years ago at the start of the COVID pandemic in Australia and New Zealand. They surveyed intensive care units around their countries, and they basically asked what was being asked of them in terms of supplying intensive care unit space to potential patients. And as you can see, they were asked to add beds in a variety of different ways. And this was seen across all their different types of hospitals, about a 200% increase in the amount of ICU beds, suggesting that sort of we were asked to do more in more space than we were used to. And whether or not this had an impact on our patients, I think we don't really know. There is one study that comes out of the early part of the pandemic in New York City. This is in the spring of 2020. And it was a retrospective study of 11 hospitals within one health system, where they had to rapidly expand their number of ICU beds to meet the COVID surge in the spring of 2020. And after doing some adjustments, they considered the outcomes of patients up to 28 days for those who were cared for in their typical, what they call traditional ICUs, and those in their expanded spaces. And as you can see here on the Kaplan-Meier curve presented here, if we look at days after intubation, so again, these were patients with COVID, primarily in the ICU for respiratory failure. And on the y-axis, their probability of survival, there really wasn't a notable difference in the likelihood of surviving to 28 days in either group. Now, you will see, obviously, that there's a significant mortality in both groups. This, of course, was before vaccination, et cetera. And I will caution us that there were probably some differences in these groups that these authors could not adjust for. For instance, people may have triaged patients who they thought were more complex, for instance, to their traditional ICUs. But nonetheless, it suggests that the space itself may not be our biggest issue. But I do think stuff is a bigger problem. And if we think specifically about respiratory failure, we know there are a lot of devices that we have available to us to help support our patients while we treat them or while they get over their disease. And so I've just sort of depicted some of them here: invasive mechanical ventilation, non-invasive ventilation, whether you use a face mask or a helmet interface, and now more commonly high flow nasal cannula. And so what do we know about this? And again, I'll just sort of highlight a couple of studies to show us, I think, what we already intrinsically know, that sort of delayed access to these sort of supportive devices may negatively impact our patients. So this was a single center study that was done prior to the coronavirus pandemic, and basically evaluated patients who had been on high flow nasal cannula and required invasive mechanical ventilation down the line. And they broke them up into patients who required invasive mechanical ventilation early, what they called less than 48 hours, or later, greater than 48 hours. And they wondered whether or not having delayed initiation of invasive mechanical ventilation greater than 48 hours would be associated with worse outcomes. And in fact, that is what they found, right? They found that the likelihood of survival was reduced substantially, about 2/3, if you had this delayed versus early initiation of invasive mechanical ventilation, if you were ultimately to need it. And similarly, the likelihood of liberation from mechanical ventilation was notably higher if you were in the early group. So again, suggesting that sort of access to this stuff, to this advanced respiratory support may be problematic if we're missing, if those resources are strained. Now, of course, this has been studied quite a bit in the COVID pandemic. Many of you may be familiar with this literature. It is all studies looking at delayed versus early initiation of invasive mechanical ventilation. And most of these studies are purely observational, sort of retrospective evaluations. And we know that those studies can be confounded, right, by the likelihood of getting intubated, for instance, based on sort of clinical assessment of how patients are doing. And so there's a lot of challenge in these studies, but nonetheless, this meta-analysis that evaluated a significant number of them found that there was not a clear signal toward the benefit of early intubation in patients who would ultimately be intubated. And so I think there's some question about what populations this may be more harmful, particularly having less access to this important respiratory support resource. But I think there's significant data to suggest that there probably are some populations in whom it will be problematic. And then I think even more obvious, and clearly not something that would be studied, and I sort of excerpted this study from the BMJ from their Christmas edition now nearly 20 years ago, where, as many of you may know, that's sort of their joke edition, right? And these authors put together a study about, or a spoof study on studying parachutes, right? And this is sort of the example of the things we can't study because it's so obvious that they will work. And I think that this is probably true for invasive mechanical ventilation for certain patients, right? There are certain patients that we know if we do not provide it to them, they will not do well. And so again, this resource and this access to stuff can have negative consequences. But I think most importantly, when we think about space, stuff, and staff, is really the staff. And the reason for this is we can always build more space, we can construct more machines, we just need sort of the willpower and the money. But it is very hard, especially rapidly, to create new qualified staff, right? New of each of us. And I think we have significant data at this point to suggest that staff, and particularly staff with expertise, matter in the care of critically ill patients. So, and a particular area of interest of mine is intensivist workload, and we now have a number of studies that suggest that there's an association with the number of patients that an intensivist cares for and the outcomes for those patients. In particular, these two studies I note, one from the US, one from France, suggesting that when intensivists have more patients, their patients tend to spend longer times in the ICU and tend to die more often. Now, I will say it's not as straightforward as that. These are two studies that I've been involved with, one in the UK on the left-hand side and one in Australia and New Zealand on the right-hand side, where we looked particularly at the association between how many patients an intensivist cares for and their outcomes. And what we found, confusingly to us, was an association in the UK where when patients were cared for by intensivists with either too few or too many other patients, they didn't do as well. But we really found no association in Australia and New Zealand. And so again, I think this calls into question, makes us remember that really our patients are a fairly heterogeneous group of people. One thing we note in these studies is that the group in Australia and New Zealand on average are less sick than the ICU population in the UK. And so this may have something to do with it, that this staffing ratios really matter in the severely ill population, but maybe less important in those who are on average less ill. But I think it's really important for us to remember that there is significant data at this point suggesting that we probably have, our workload probably has an impact on how our patients do at least in some settings and for some segment of the population. And this is not unique to us. Actually, the nursing literature is substantially more robust than that for physicians. I just call attention here to one study. This was a meta-analysis done a few years ago of 6 studies looking at nursing ratios in acute care units, inclusive of ICUs, but also post-operative care units and emergency departments. And they found fairly consistently, and you can see that in the forest plot here, and then when meta-analyzed, confirmed that when patients were cared for by nurses who had more patients, they were less likely to survive. In this case, it was survival to hospital discharge and or a certain period, for instance, 30 days, depending on how the study looked at it. So I guess one response to this, right, would be that we just need more of us, and maybe it'll take time and we just need to educate more of us. But we know that we have this pervasive problem, right, where no matter how many more of us we educate, we have increasing amounts of burnout, particularly in critical care, that may be sort of threatening not only the pipeline, but also sort of making it leaky on the other end to cause many of us to leave the profession. And so these are studies from around the world that I just compiled here on one graph, just to show you that there's, I think you guys know, fairly high rates of burnout amongst ICU clinicians overall. And this was only exacerbated again by the COVID pandemic. And I think this is something we've all felt, but we know that recent studies have shown that around 50% of clinicians of all types who work in the ICU across the globe are now experiencing burnout. So we have this problem where in order to take good care of our patients, especially in times of strain, and especially those that are most critically ill, for whom those with respiratory failure, I think would be the sort of exemplar, we either need more clinicians or we need fewer patients or we need both. And I think we need to think about the solutions that can do both of those things and talk about where the potential benefits and then the potential downsides are. So in terms of increasing clinicians, the easy thing to say, right, is create more of us and hire more of us. But of course, we need money for that. And then we also need qualified people, which means we need a pipeline and we need to sort of plan in advance and we need to have more medical education or nursing education spots, et cetera. So that's a lot easier to say than it is to do. The other thing, which I think is done very commonly, and many of us have experienced this, is that we ask the clinicians we already have to just work more, right? If your standard was to work three shifts every 7 days, for instance, maybe you're asked to work 5 or 6 or whatever it might be. And of course, that allows us to cover the patients better in the short term, but has the challenges, first of all, that we may be distracted and or tired, and therefore we may not provide the optimal care we do previously, but also that this may exacerbate burnout. And there are studies to suggest that increasing workload does that. And then finally, I think there's sort of the novel strategies, and I'll just highlight one in a moment, of how do we use the workforce that we have now to effectively expand our reach without demanding necessarily more of the individual clinicians. And so this is just one example that was put out by the Society of Critical Care Medicine, again, at the start of the pandemic. This was sort of initiated by Neil Halpern. And they talk about, in many other environments, propose this same exact idea of sort of expanding our reach by creating sort of teams of care similar to what we're used to in the ICU, but bringing in providers or nurses who are not our typical ICU clinicians, but working closely with us. And so this is just an example. The practitioners in green are the ones that are typically in the ICU, and all the ones in red are other types of practitioners, nurses, physicians, advanced practice providers that work sort of similarly to us, alongside us, who we may be able to sort of ingratiate into our team to help expand our reach. And this was done in some places. And I know that this really scared people, certainly did in our institution when we talked about doing it. We only had to do it for a couple of days. But I should point out that we essentially do this in the ICU all the time. So this is data from a study that we were able to conduct, again, with data from Australia and New Zealand, where we asked the question, if we didn't look only at intensivists, but we looked at the other physicians in this case, there were no advanced practice providers, so other physicians that are in the ICU to sort of help them distribute the workload. Were we able to see that intensivists in general created a team that was evenly distributed? And so as you can see here, these ICUs, we had 123 of them, of which most had intensivists as well as non-intensivist physicians. And when we looked overall on how many beds each of the physician groups tended to care for, if we looked only at the intensivists, they cared for a large number, 7 to 8 with wide variability, But once we added in the non-intensivists and particularly put everybody together, you can see that obviously the workload shrinks for everybody because we're combining everybody, but also the variability shrinks, right? It's almost as if across units, we've learned intrinsically to balance. So if the intensivist has more patients, well, let's bring him or her additional support, right? So this is something we already do. And so the idea of tiered staffing, I think, shouldn't have scared us. And in fact, just to harken back to the study I mentioned before from Australia and New Zealand, if this is done well, this can work, right? This is, again, that plot showing that there was no difference in how patients did, particularly related to hospital mortality, if their intensivist had more patients to care for, likely because in addition to having relatively lower acuity, they were offset or helped by these other team members. Okay, so that's how we might be able to increase clinicians. Well, how might we decrease patients? So the first thing we can do, of course, is turn people away. That's not what we used to do. It's what we had to do in many ICUs or maybe many critical care settings at the beginning of the pandemic, but that clearly is not our goal. But I think the other way, and this is one that we've really pushed for, right, is to try to expedite throughput through the ICU, to get ICU patients out faster, and to get mechanically ventilated patients extubated faster so they get one step closer to going out. And while I think this is a brilliant idea and really where we need to focus, I just want to give you some cautionary examples of why we may need to think while we're doing this about whether or not we're doing harm. So I'm going to focus on that extubation example, in particular because, again, respiratory failure patients are really sort of the epitome of the critical ill. And so I just want to show you two examples of where attempts to expedite care may actually have negative outcomes. So this is one study that, that we were involved with looking at patients in the US in sort of general medical, surgical, and mixed med surg ICUs. And we looked at people who were mechanically ventilated for at least 12 hours, thought to be sort of more like your typical respiratory failure patient rather than those that may be post-procedurally. And we asked the question, well, what if we were able to extubate them overnight? How did they do? Because that might be a way to expedite care, right? Many units don't do that. On the left hand here, you can see that this is our primary outcome of reintubations ever during their stay, and then ICU and hospital mortality. And what you can see is for the full group of nearly 100,000 patients in 165 ICUs around the country, we found actually that there was an increased risk of reintubation associated with overnight extubation in this general mixed med surg cohort, which was also associated with increased ICU and hospital mortality. But if you sort of drill down, you can see that really the signal appears to be in medical admissions, so patients who were never in the operating room, and those in medical ICUs, as well as a suggestion that these were concentrated in units that did not have intensivists in-house overnight. So again, there may be some places in some populations for which this is safe, but not all. And just to reiterate that, this was a repeat of the same study looking at cardiac surgery patients. And in fact, if anything, with overnight extubation, the only thing we saw was reduced ICU length of stay without a need for readmission, with no change on reintubation. So this might be a population for which this is safe. And then on the flip side, another group that we, and I certainly have advocated for trying to remove from mechanical ventilation early, are patients who remain on vasopressors, because often it's the mechanical ventilation that mandates the ICU setting and obviously all the complications of that. And so this was a study that I was able to be involved with one of our trainees using data from Calgary in Canada. And what she asked was there a difference in the outcome, particularly reintubation, but also mortality and length of stay associated with extubating people while they were on high or low dose vasopressors versus none? And as you can see here in the forest plot, and I've tried to summarize here on the right-hand side, extubation on high dose vasopressors was unfortunately associated with poor outcomes, much to my, contrary to my hypothesis. So increased reintubation rates, increased mortality, increased length of stay. However, low-dose vasopressors, which she defined as less than 0.1 mics per kilo per minute of norepinephrine or its equivalent, was not associated with bad outcomes. And so that might be a group in who we can target earlier extubation. And so in summary, what I would say is I think strain can occur in the ICU in general and in respiratory failure in specific, in space, staff, and stuff. And it's important in all of them, but I think the key is probably the staff. It's hardest to manage the staff, but there may be solutions that exist if we're willing to think outside the box. So an example would be tiered staffing. Another example, which I didn't show data for here, might be alternating schedules, where studies have shown that the same number of clinicians can provide the same care without changing patient outcomes, with less burnout if you change the way they're scheduled. And then finally, I think we should think about clever ways to lessen demand, particularly patient throughput, but we have to be cognizant of the potential downsides of this and just be mindful and aware of them. So that's all I have. Thank you so much. And I look forward to the rest of the session.
Thank you, Haley. That was fantastic. So that's the first of our 3 sessions. I want to thank Haley. And then I'll introduce our next speaker, Donna Tanner. So Donna, thank you. Good to see you, Donna. Donna is a respiratory therapist with nearly 30 years of experience specializing in adult critical care. She's a specialist and an ECMO specialist, particularly who works at the Cleveland Clinic and their main campus in Cleveland, Ohio, where she has continued to serve as the education coordinator for the respiratory therapy department. And most recently, her role within the Anesthesiology Institute is the clinical program manager for the rapid response and resuscitation teams. So she is going to talk to us about respiratory therapy-driven protocols and the future of those. So Donna, let me hand it over to you, and thank you for being here. You're muted.
Thank you. Thanks everyone for the invitation. Are my slides up? Can we confirm? Okay. So again, respiratory therapy driven protocols, and can we redefine their future? I do not have any disclosures for this talk. So our objectives today are going to be to review the history of therapist-driven protocols, to assess the current state of the protocols, and define what the future can look like. So just a quick review on this are the whys. What are the therapist-driven protocols and what are they designed to do? And these protocols are developed to contain costs, to manage respiratory patients, allow the RTs to practice at the top of their license, and to define positive outcomes. So history-wise, changes to the reimbursement of respiratory care services over about the past 30 plus years made it imperative for RTs to demonstrate cost savings to establish their value. Evaluation and studies have taken place over the decades to institute these therapist-driven protocols so the RT could assess and treat the patient and evaluate the effectiveness of ordered treatments for modifications based on the patient's response. The formal studies that happened around 2015 focused on the professional need for the RT to practice at the top of their license through the protocols. And, when we talk about therapist-driven protocols, of course, mechanical ventilation protocols always come to mind. And the first thing we have to think about is, just really think about the ARDSNet protocol. And now they go into even post-CABG patients, CVICU patients, mechanical ventilation with ECLS, whether it happens to be VV ECMO, VA ECMO, our lung transplant patients and medical ICU. Disease management-wise, we can talk about protocols that we've had for COPD patients, asthma patients, IPF patients. And through these therapist-driven protocols, it gives the RT the autonomy to practice at the top of their license through a detailed patient assessment, to order the treatment, to evaluate the response, and to modify those parameters as indicated. So let's fast forward to January of 2021, when we talk about the endless question of inhaled nitric oxide on the adult population. We know nitric works, we know it's expensive, and we know of other inhaled alternatives that are just as effective with a portion of the price tag. And you can't truly speak of any RT cost savings in value-based treatment without mentioning INO. So in January of 2021, Respiratory Care published an article titled Respiratory Therapy-Driven Protocols, an important component to decrease overutilization in medicine. And it was by Rogerson and colleagues. And here the team developed a protocol with inclusion and exclusion criteria. It had a tight algorithm for the initiation, weaning, and discontinuation of nitric, and it offered alternatives due to INO's low evidence of improving outcomes. The challenges faced through this protocol were the team had realized that there was a lack of awareness of the protocol right within its own institution. And then there was a lack of willingness of the physician staff to adhere to the protocol. So in response to that, the authors described a very straightforward weaning protocol that was based on pulse oximetry and hemodynamic changes, including arterial pressure, central venous pressure, and right atrial pressure if they were available. And then Rogerson and colleagues elegantly described the utilization of the Institute for Healthcare Improvements model to develop and implement this protocol. So using the PDSA cycles, which is the plan, do, Study Act, they determined that the greatest opportunity for improvement was centered around the variances of INO, the duration and the cessation of therapy. And knowing that the mentioned challenges of organizational lack of awareness, they created these bedside laminated cards and also started weekly huddles to improve this. So now it was always something that is going to be talked about, and the awareness was right there. And through the successful implementation, the INO protocol led to a 39% reduction within 9 months, which translates to just over 500 hours per month in this hospital. And it was a yearly cost savings of over 900,000 US dollars. So current state of therapist-driven protocols, we know that we want to be fiscally responsible caregivers. We know that we want the ability to work autonomously within our scope, and all of those factors help engage the RT, retain the RT, and build relationships between the multidisciplinary team. So here there was a single center study by Pratt and colleagues from Duke that was published in December 2021, Critical Care Explorations, and it implemented an RT-driven protocol to assess if patients could be liberated from VV ECMO, and looked at the time of first initiation of sweep-off trial, the duration of mechanical ventilation, ICU length of stay, hospital length of stay, and survival to hospital discharge. Concluded with stating that daily RT assessments of sweep-off readiness were associated with shorter ECMO runs, and among the survivor group, it was reduced mechanical ventilation and ICU length of stay, but there really wasn't any shown difference between hospital length of stay or mortality. But overall, this study was truly the epitome of what a well-defined therapist-driven protocol can do for an organizational cost, the RT and the patients all in one. So what does it take to develop a therapist-driven protocol? It takes knowing what type of protocol do you want. Do you want an algorithm? Do you want a descriptive narrative? Do you want something very, very descriptive where there's no chance for any error and there's just lots of words that happen to be in it? Do you want it to be prompted by standing orders that the physician goes ahead and orders it, or by admission diagnosis? And no matter what happens, it's keeping in line with the view that this is a delivered individualized care. This isn't an all size fits one. Every single patient does not fit the algorithm. Every single patient does not fit the protocol. And by doing this, the RT can assist the physician with the patient evaluation for the needs. We can determine indications for therapy and the appropriate modalities, again, delivering high quality, cost-effective care that really improves our outcome, decreases our lengths of stay. And, to reiterate, just the empowerment to allocate the best care based on the algorithm. So now you've created the protocol. How do you sustain it? Well, it takes the RT to really know how to gather the clinical information, make that assessment based on the data, initiate, modify, and at times discontinue the therapy, and properly communicate with the team. You have to pay special attention to the skill knowledge and the knowledge base to really sustain the protocol. And this is a challenge in success because we know, as all clinicians, not just RTs, we all really assess at different levels. So it's about using a protocol where everyone has the same assessment skill. So organizationally, that should be the responsibility on the onboarding process to be sure that every RT, while you're instituting these protocols, is at the same level of assessment. The RT should have a quick, systematic approach to gather the patient data, to then formulate the accurate assessment of that, select the appropriate treatment, and of course, documentation. So as we look at the future, what does the future look like? Pandemic versus the non-pandemic state. So the pandemic taught us a lot, and therapist-driven protocols were around well before COVID came and even before H1N1 was here. But our mass teaching of non-RTs to help out during COVID allowed us looking at therapist-driven protocols as algorithms to follow. We look at mechanical ventilation ones, think back to our high flow, our proning, just standard oxygen therapy with our COVID patients. We developed protocols for just about everything. So non-RTs that were helping out, with these patients at that time could easily follow an algorithm, follow the arrows, and help treat the patient. Staffing, we look at the future of staffing challenges, and we foresee protocols to help assess workloads, can the RT safely and effectively get to a point to modify or discontinue something that's been ordered for a few weeks with the care team? Is it something, we all have those times of the quick orders, and then maybe something's gone and we've gone a few weeks, a few days, and we haven't really, revisited that. So can we reduce workloads? And then providing optimal care for the patient. We really need to, again, decrease the duration of mechanical ventilation safely, reducing costs, length of stay, and then we can look at improving rates of weaning, whether that's through spontaneous breathing trials for mechanical ventilation, again, for ECMO runs, and a combination of both of those. So we look at all of this and, we see the weaning processes, whether it be mechanical ventilation, whether it be your oxygen therapy, whether it be aerosol therapy. These are all continuous improvement plans. They are all quality plans to, again, decrease your ICU length of stay. And it's always that constant evaluation of effectiveness. We have to look at the fact of, is it being effective? How often are our patients being reassessed with this? Is it per your protocol every 8 hours, every 12 hours? Is it every 24 hours? And then knowing that we can protocolize more than just critical care, standard oxygen therapy, bronchopulmonary hygiene, anything COPD wise, and even disease specific management. We have certain protocols for all of our CF patients. We have asthma protocols. And the knowledge to know that even when these challenges occur, as far as staffing challenges, that regardless of the situation and the challenges, your patients are getting the optimal care based on the assessment that's there. And I flew through that very quickly, but that is all that I have, and we can welcome any questions. Thank you.
Thank you so much. That was an excellent presentation. Now it is my pleasure, eres un placer para mí presentar al Dr. Dan Talmor. Dr. Talmor is the Edward Lowenstein Professor of Anesthesia. He's the current chair of the Anesthesia, Department of Anesthesia at Beth Israel Deaconess Medical Center. El Dr. Talmor es el chief de Anestesiología en el Beth Israel Deaconess Medical Center. Para mí es un honor presentar al Dr. Talmor. Lo voy a hacer en español porque quien soy hoy, una persona que se dedica a la ecocardiografía en cuidado crítico, fue él quien me dio la oportunidad hace 13 años en su institución en poder desarrollar mis destrezas. Quiero que empiecen a pensar en preguntas también en español y yo voy a poder ser capaz de traducirlas al inglés y a ustedes nuevamente al español. Please welcome Dr. Dan Talmor. Danny.
Thank you, Jose. I didn't understand a word, but it sounded very complimentary, so I really appreciate that. And I'm very proud to say that Jose trained with us for a short time, and I've been watching his career grow and prosper ever since. So the topic of my discussion today is personalized therapy for respiratory failure. And this is really a personal view of the way mechanical ventilation and treatment for respiratory failure has developed over the years and where it's heading in the next 10 years. So please bear with me. And if we start by looking backwards, our concentration at the beginning was on restoration of normal oxygen and CO2 levels. We thought that that was the cornerstone of treatment, that if we could keep the oxygen level high, CO2 levels normal, the patient would then recover. And when the acute respiratory distress syndrome was first described 55 years ago, that was the approach that was taken to treatment of the disease. And the first intensivists learned from the first anesthesiologists, and they had discovered in the early 60s that by increasing the tidal volume and adding hyperinflations, we could prevent atelectasis during surgery and maintain an adequate PaO2. So that's the starting point for mechanical ventilation in acute respiratory failure. And when Petty and Ashbaugh, the two people who described ARDS, published their recommendations on the management of ARDS, They wrote this: we have learned that a high tidal volume ventilation with both an inspiratory plateau and positive end expiratory pressure improves oxygen transport across the lung. So for the first decade of treatment of ARDS, maintain a high oxygenation by using high tidal volumes and some level of PEEP. Now, in those years, people started to develop an understanding that this may actually injure the lung. And if you look on the left-hand panel, you can see that after 20 minutes of ventilation at a high peak airway pressure, these animal lungs are essentially destroyed. On the right-hand side, you can see an interesting experiment by Webb and Tierney from 1974. The right-hand lung is high pressure and low PEEP. That lung was destroyed by mechanical ventilation. But the middle lung, which had high pressure but high PEEP, that lung maintained its integrity. So this paper led to the concept of lung protective ventilation and the understanding that the combination of high pressures and high tidal volumes leading to cyclic collapse could, in a susceptible lung, induce ventilator-induced lung injury. So high pressure, that's the stress on the lung. High tidal volumes, that's the strain on the lung. If we don't have enough PEEP and we allow the lung to collapse at end expiration, all of this will make the sick lung sicker and lead to ventilator-induced lung injury. So our focus shifted from maintaining normal blood gases to preventing ventilator-induced lung injury. And this was the focus of research in the 1990s and the 2000s. The concept was pretty simple: lung protective ventilation, lowering the tidal volume, adding some unknown level of PEEP, rather than the curve you can see on the left hand, which is a higher tidal volume and no PEEP. So by using lung protective ventilation, the hypothesis was that we could protect the lung from further injury. And that seemed to be borne out in the famous ARDSNet low tidal volume study. So you can see here, this is the survival graph of patients ventilated with 6 mLs per kilo versus 12 mLs. And the difference between those two curves is prevention of ventilator-induced lung injury. So this seems to be case closed. Low tidal volume is a good thing, but not so fast. Is it a good thing for everyone? When people went back and reviewed the ARDSNet low tidal volume study, they found, and this is really an excoriation of the paper by Deans, they found that the patients who were screened for the study but not randomized because they were otherwise ineligible, all of those patients were actually receiving 6 mLs per kilo of tidal volume or less. And the mortality rate among those patients was actually lower than the patients in the study. So the question became, did this study really test low tidal volume versus standard of care, or did it test standard of care versus high tidal volume? And the difference is important. In fact, there were patients in the study who were actually harmed in both arms. So if you look at the solid circles, those are patients with a lower pulmonary compliance. When the tidal volume was raised in those patients, so up here, the tidal volume was raised in patients with a low compliance, their mortality rate was very high. So patients who were randomized to a higher tidal volume in that group really suffered. On the other hand, patients with a higher compliance, if their tidal volume was lowered, they were likely suffering from atelectasis and a higher mortality rate also. So while the concept of lower tidal volume is important, the religion of 6 mLs per kilo is probably not the appropriate lesson. And we need to think about individualizing not only PEEP, but tidal volume to our patients' lung compliance. Now, what do people do in the wild? So this is the Lung Safe trial, a very large survey of mechanical ventilation around the world. And you can see this is the distribution of tidal volumes that were seen in that study. And this is 6 mLs per kilo right here. So only a minority of patients with ARDS around the world receive tidal volumes of 6 mLs per kilo. In fact, most were in this range of 6 to 8. And this, I don't think, shows that there's not good practice around the world. I think it shows that clinicians around the world are thoughtful about the tidal volume they give their patients, and they understand that you can't protocolize it to 6 mLs per kilo for everyone. You have to think about your patient's level of injury. The same goes for PEEP trials. So PEEP trials, I'm sure everybody on this call is aware, have a very mixed history. There's been multiple large trials of levels of PEEP, some set by the lower inflection point of the PV curve, some set by tables, others set by the plateau pressure. All of these trials were either negative in terms of there was no signal, or else some, including the ART trial, actually showed harm from higher levels of PEEP. But we can look at these trials the same way. If you take patients and you give them 6 mLs per kilo, so a low tidal volume, and you randomize them to lower versus higher PEEP, and you see no difference, you have to ask yourselves what's happening in that higher PEEP group. And in fact, that higher PEEP group probably contains two separate populations. One is non-recruitable patients. In those patients, I increase the PEEP, I push the plateau pressure up, and I increase the driving pressure because they're not recruitable. I'm just increasing the pressure in the lung. And in those patients, the injury from high PEEP will outweigh the benefit. On the other hand, recruitable patients, those who have atelectasis, those whom I actually open up lung, when I increase the PEEP, I will drop the driving pressure because I've recruited more lung, the pressure distributes more evenly, and in those patients, the benefit outweighs the injury. Unfortunately, almost no PEEP trial has actually looked at trying to identify recruitable versus non-recruitable patients at entry to the trial. And the way to do this, and we've published on this, is using the concept of transpulmonary pressure. So the transpulmonary pressure is the airway pressure minus the pleural pressure, and that's the pressure actually distending the lung. And if you look at the transpulmonary pressure prior to adding or increasing PEEP in the patient, you will find patients in whom more PEEP is required and patients in whom less PEEP is required. So it's actually a measure of recruitability. And you have to measure the transpulmonary pressure because, as this graph shows, it's very different from the airway pressure. It's different based on the component of the pleural pressure. And we estimate pleural pressure using an esophageal balloon. So individualizing tidal volume, individualizing PEEP is the way of the future. So prevention of ventilator-induced lung injury, we've now moved on to the concept of self-induced lung injury and risks to the diaphragm. And these are interrelated issues. They're highly connected. And the problem is we can't really go from controlled mechanical ventilation to extubated. We need some interim stage where the patient is breathing spontaneously. And how to do that in a safe manner is a key issue in mechanical ventilation right now. How to make sure that when we transition to spontaneous ventilation, the patient's not injuring themselves. And why would they injure themselves? So here you can see graphs of ventilator flow, pressure in the airway here in green, and tidal volume here in black. Now here is esophageal pressure, this purple line. So we have a balloon in the esophagus measuring the pressure, and when the patient takes a deep breath, the esophageal pressure goes way down. So these gasping breaths while the patient is mechanically ventilated lead to breath stacking So you can see here the patient's the patient's tidal volumes are very high, and the pressure in the airway is very high. The difference between these two is the driving pressure, and it's going to be ginormous in this patient. So spontaneous ventilation on controlled mechanical ventilation can be extremely dangerous. And this phenomena can happen under pressure support as well. So those high stacked tidal volumes can be much more than 10 mLs per kilo. And dysynchrony has been associated with mortality. So this study out of Spain, small study, but showed that patients with an asynchrony index of more than 10, so high number of asynchronous breaths, those patients had a high ICU and hospital mortality. So we know that asynchrony is bad for the patients. We know that spontaneous breathing inappropriately can be bad for the patients. On the other hand, and there's always another hand in medicine, and particularly in critical care, not breathing spontaneously in totally controlled mechanical ventilation can lead to diaphragm atrophy. So if this is the normal thickness of a diaphragm, patients who were ventilated for even 2 days had substantial loss of thickness of their diaphragm. On the other hand, patients who were breathing spontaneously on the ventilator, those patients who were making inspiratory efforts had a preserved and even increased thickness of the diaphragm. Why is this important? Because when the patient needs to breathe on their own, when the patient's extubated, diaphragm thickness is going to be very important in their ability to maintain their ventilation. So this would seem to say we need to keep the patient breathing spontaneously in spite of the risks. Now, how do we square those competing problems? And I think the answer is in this. So this is a paper by Takeshi Yoshida. He took animals with mild lung injury and severe lung injury. And when the animals with severe lung injury were breathing spontaneously, they made themselves worse. You can see a worsening lung architecture in those patients. On the other hand, mildly injured patients, when they breathed spontaneously, actually they improved. So maybe the answer is to look at the severity of the ARDS of your patients. Until the patient's ARDS begins to resolve, don't let them breathe spontaneously. And this is, by the way, the rationale for paralysis. But when they are improving, that's the time to begin to allow them to breathe spontaneously, maintain their diaphragm, and get them ready for extubation. So learning from these past 4 decades, in this decade, we've really been concentrating on phenotypes of disease based on mechanical and clinical factors. And we have to first recognize the huge heterogeneity of patients with ARDS. So you can have ARDS from sepsis, from hemorrhagic shock, from trauma, from pancreatitis, from aspiration, of course, COVID-19, which is obviously a subset of ARDS. We have a hugely heterogeneous syndrome of ARDS. And we have to understand that treatments for one type of ARDS may not be appropriate for another. So what do? I start by assessing the patient's pulmonary mechanics. And this is a tracing of airway, esophageal, and transpulmonary pressure in a patient mechanically ventilated. This was a trauma patient. The patient's airway pressure was going from a PEEP of 13 to a plateau pressure of 40. But the esophageal pressure was very high. This is a patient who had a pretty severe chest contusion, who had received massive fluid resuscitation and had a distended abdomen, all of which will increase the esophageal pressure. The transpulmonary pressure was 6 at end inspiration, so very low. And at end expiration, it was actually calculating negative. That means that the pressure of the chest wall at end expiration was actually higher than the pressure in the lung, and the lung was collapsing. So what did we do with this patient? We increased the PEEP from 13 to 26. That increased the plateau pressure from 40 to 46. And if you look, that maneuver, that recruitment, even though it was extremely aggressive, right? Not many people on this call, I expect, routinely use a PEEP of 26, brought the driving pressure down from 27 to 20. Still not great, but obviously much better. So personalizing mechanical ventilation based on the patient's pulmonary mechanics. And we've shown that if you keep the transpulmonary pressure plus or minus 2 centimeters of water at end expiration, patient survival is better than those with either a higher or a lower transpulmonary pressure. So titrate your PEEP to keep a transpulmonary pressure around 0. We'll be imaging the lungs more, and we've learned a lot from lung imaging. First descriptions of CT are now 30 or 40 years old. We learned that the problem in ARDS is often collapse and consolidation to the point where we're only ventilating these baby lungs anteriorly. But it's extremely difficult to take an ARDS patient to the CAT scanner. We now have bedside imaging, which is useful. So this is a picture from an EIT machine showing ventilation of the lungs during a mechanical ventilation. And we can see the distribution of ventilation, and it actually compares really well with the CAT scan. So this is a CAT scan of a patient with a very large consolidation and a sick right lung here. You can see that that is seen on the EIT machine. We can see that that area is not ventilated. And by looking at areas of collapse and hyperdistension, we can find the optimal point for recruiting the lung under EIT. And EIT, I was always very skeptical because for 15 years, people have been showing me pretty pictures of EIT machines. It's here. We have useful machines at the bedside, and this can be done. We'll be looking at biomarkers. So again, something I've been skeptical about over the years, but they're now becoming actually useful. So there's multiple biomarkers associated with ARDS. There's markers of epithelial function, endothelial function, general inflammation, coagulation. All of these have been measured and quantified. And great work has been done in defining hypo and hyperinflammatory ARDS. And this work was actually useful during COVID when we started to test IL-6 inhibitors in patients with COVID-19. We looked for the patients with hyperinflammatory ARDS. So you can build a profile of patients with the hypoinflammatory subtype. So for example, trauma patients or patients with perhaps pancreatitis. So these are patients in whom collapse probably plays a bigger role than inflammation. They tend to do better, but we can also find the hyperinflammatory patients, those in whom inflammation is playing a major role in their ARDS. Now, why is this important? It's theoretical, right? But it's become important because we can now look at drugs that may benefit one or the other group. So this is the simvastatin in ARDS study that was published several years ago. I forget when. This paper was essentially negative. But when they went back and reanalyzed the study, dividing patients into hyper and hypoinflammatory ARDS, they found that really it had no effect on the hypoinflammatory group. So trauma patients don't benefit from simvastatin. But in the hyperinflammatory group, so the septic patients, the ones with pneumonia, etc., simvastatin actually did improve outcome. So this was a drug that was inappropriately thrown away. But when we relook at the study based on the patient's inflammatory state, it appears that it was really inappropriately discarded. So where are we now? We're at the point of personalized ventilation based on the patient's phenotype, and decision-making using full automation. We have the ability to identify desynchrony on the ventilator. New ventilators are going to tell us what type of desynchrony there is, and they're going to be giving us suggestions of how to modify the ventilator settings. We're going to be looking at lung protective sedation. So the answer to desynchrony is not always increase the sedation. It's sometimes decrease the sedation. We're going to be looking at new drugs or old drugs, re-looking at them to try to put the patient in better synchrony and eliminate that desynchrony injury. And finally, closed loop ventilation. This already exists in Europe, and I know many of our Spanish colleagues are probably familiar with ASV and IntelliVent and the various variants of that. This is going to be coming also to North America one way or another to try to improve the delivery of mechanical ventilation. So enriching patient care, image guiding phenotyping, physiological phenotyping, biomarkers and phenotyping patients based on their inflammatory state. All of this is going to give us an integrated approach to prospective decision-making in the next decade, supported by innovations in mechanical ventilators. So there's never been a more exciting time to be treating patients with ARDS. Thank you very much.
Thank you, Dr. Talmor. Greg, please.
Yeah, thank you to all of our speakers and everyone for joining us today. So I want to open this up to questions. If anyone has questions, please channel them in. We'll be happy to ask our speakers. I'll start off with one, and let me go back to our first speaker, Dr. Gershengorn. So the question is about, you talked a lot about the space stuff and staff that are working in the ICUs. And we tried to expand all of those. And in many ways, as you showed, we tried to expand staff with tiered staffing models and so forth. And the space, we certainly opened new ICU space. The stuff, the other equipment and so forth, it seems like we struggled a bit more about. So I guess there's sort of two questions there. One is, are we thinking about that, or am I thinking about that correctly, that maybe the stuff is harder to expand in some ways? And then I guess the related question is, what do we know about sort of the things that might tell us whether we're doing that successfully, if we are expanding the spaces and the staff that are doing this work in the ICU?
Yeah, so I think, thanks for the question. I think based on what I presented, I would agree with you that stuff and staff are both harder to expand than space. That's pretty obvious, right? Space, we could probably run an ICU in a hotel room if we had stuff and staff, right? That really doesn't matter. I think the one caveat I would put to that, and maybe this gets a bit to your second question, Greg, is, how well are we doing it? So I think we have lots of people around and we don't have lots of ventilators around, for instance, right? And the question is, are we asking the people to do something, even in a tiered staffing model, that they are qualified for the role they're being asked to do? And how do we measure that? And so I think on its face, we can expand our staff more quickly. The easiest thing is to turn to our, infectious disease colleagues and ask them to come, work with us on a team or whatever it might be. But I think we saw certainly in parts of Europe and were reports of people really outside of their element, right? Physicians who had not been clinical in a while being asked to do these things. And that probably is the extreme. So I think in that sense, we can expand staff, but how well they're doing. And I think it's much harder. It takes much longer to train the next ICU nurse than it does to build another ventilator. Now, I think ventilators are a little bit easier. We either have them or we don't. And as you sort of allude, we divert resources to other things, but that are probably suboptimal. So to me, those are both challenging. And my guess is that if we knew how best to allocate the stuff that's strained, we could probably do better with that than we could allocating the staff that's strained. But how to figure out who those right groups are, and do we know that enough now? I don't think we do. So I think you're right. In this current context, I think it's both of those two things.
Yeah. Good. Thank you. Other questions? Jose, do you have questions?
Yes, there is a question for Danny. Of course, Danny, we have all this heterogeneity. And so let's say we have so many subphenotypes. So the question will be, having all these biomarkers, all these subgroups, the different severity, how will we choose which stratification method is best to study or implement each new intervention? You have so many, I would say, factors in place.
Yeah, that's a good question, and it's definitely going to be a challenge for study design. But I think it's in part going to depend on the intervention we're studying. So, for example, steroids. There's no reason to think that we can't give steroids, but also use the patient's pulmonary mechanics to improve the actual ventilation, and at the same time use the ability of the ventilator to automatically detect asynchrony to also tweak the ventilation. So I think it's going to be a combination of all, and we're going to be forced to think more carefully about each individual patient. I suspect that many drugs have been tested in ARDS. Essentially, as you know, every study's negative, but maybe it's because we've been lumping everybody together, and we need to go back and look and see if those studies weren't inappropriately considered negative because we had been testing them in patients with trauma, with hemorrhagic shock, and with sepsis at the same time. So I think the lesson from simvastatin is extremely illuminating, but we're going to be assessing a patient on multiple levels in order to provide optimal care across the board.
Thank you.
And I might ask another question of Donna, just to reflect back on what you were talking about. And one of the things I was curious about is you talked a lot about the necessity for practicing at the limits of the license. And in my experience, there's a couple of challenges. One is really empowering the respiratory therapist or any professional working in the ICU to feel confident and comfortable that that's part of their role and that they can do that. And then sort of related to that is, how do you get the other professionals to support them, whether it's, you talked about the physicians and whether they would buy in and feel comfortable with that and perhaps delegate some of that responsibility to the other professionals in the ICU. Tell me a little bit of sort of how you spin up a protocol or a practice like that, and what does it take to get all those people working together?
Well, thank you. It takes a village, and that's where we really start. So any development of internal organizational protocols should really not be just respiratory therapy developing the protocol. It should be with the physician staff, with the APPs. We've developed ECMO protocols that we made sure we invited PT, we had physical therapy in there. So it is not just Donna Tanner's view on how to take care of this patient. It is a multidisciplinary approach. And by that time, we have buy-in and we have people look at it and edit it and, and give some opinions with it. So it's all about building those relationships and those bridges and knowing, again, and also knowing that maybe, this patient isn't going to fit this algorithm or this protocol, and being flexible enough to know to do what's best for the patient and jump off of it. But I really do think the best approach is to, go into it with a multidisciplinary team and start to, go ahead and develop it and practice it and see what happens from there.
Is part of that then related to sustaining it over time, that you have someone who's a champion and you're always looking at it and changing it, improving it, and so forth?
Without a doubt. I think they need to be constantly reassessed. And then sometimes we have these protocols that we look at, and now we've gotten another protocol just off of that because we've had a diverse patient population come in. Really, we can, jump back to COVID, and we had these already working protocols. Well, now all of a sudden we had a dedicated high flow protocol for our COVID patients. We had dedicated things. So they're ever changing. We are assessing them all the time. And really, we're assessing for effectiveness, because maybe what we thought worked 2 years ago, 5 years ago, 10 years ago, it doesn't work anymore. So we always just have to make sure that we're doing the best thing, and the constant reevaluation of the protocol itself. And then the constant evaluation of the team as well, just to be sure that, again, you have those clinicians all at the same level, trying to make those decisions at the same level. You know, and that is challenging. It's challenging with our new grads. It's, you know, challenging with everyone. So
if I can just speak in there, half of what I know I learned from a respiratory therapist here at BI, Ray Ritz, and maybe more than half. And it's on us physicians to embrace the respiratory therapists, and speaks also to what Haley was mentioning. We can't do this on our own. We need to build teams and to support professionalism among RTs, because it undoubtedly delivers better care, and it makes the environment more fun if everybody is constantly striving to do better.
Thank you.
Yeah.
So, Greg, I would like to really take the opportunity to ask Dr. Hershenhorn regarding that specific aspect of burnout for intensivists, and even here locally, and I'm experiencing a situation that probably we are considering to have a steering committee specifically for burnout. I want your thoughts in that regard, Dr. Hershenhorn.
I suppose I have lots of thoughts. I'm not sure I'm a burnout expert, but I'm more than happy to talk to it. I think just to get back to what Donna and Danny were both saying, right? I think part of it is making it a better work environment for all of us. And so part of that is the team and building the team and having everybody work at their professional maximum. That makes it sort of a better experience for everybody and may actually mitigate some of this. I think, you know, the ICU is a good place to study this or to implement new things, but burnout's a problem, of course, across a large portion of our professions outside of the ICU as well, and COVID has exacerbated that. I think as you know, this is sort of not my area of expertise, but I would argue that I think we need to do a better job of pivoting in the way that we've all started to, away from the person being the problem to the system or the environment or the setting being the problem. And I think, at least in institutions that I'm aware of in organizations, we know that, right? We know that if somebody's burnt out or a number of people are burned out, it's probably not something about their intrinsic character flaw. It's something about the system. But I'm not sure, at least from what I've observed, that we've done a good job of figuring out how to fix that, right? I think we're better at talking about it, saying it probably isn't Haley, it's probably the environment she's in. But how do we actually set up structures to fix that? And I don't have a good solution to that, or even a thought on that, frankly. But I think that that's going to be the next frontier, so to speak, is how do we really go from identifying that to improving?
Thank you. And we will follow up that specifically whenever you are in a situation that you are not at the level of, let's say, board of directors or CEO, and really transpire all these changes across the board is a challenge. And how we start doing this from the ICU, our own climate, and go beyond that. All right, Greg, and I will say a couple of words in Spanish. Espero que, por favor, si alguien tiene alguna pregunta, la exprese, no hay problema. No se sientan intimidados. Estoy representando aquí el SCCM. Para mí sería un orgullo poder facilitarle la comunicación con nuestros expertos. Así que si por favor alguien está conectado y tiene una pregunta, la puede comunicar y yo se la traduzco. El apoyo de Distribuna, ¿saben si hay alguna pregunta?
No, señor, no tenemos preguntas por ahora.
Doctora Ayala, ¿no? So no, there are no questions in Spanish. No questions from this tribuna. Okay, Greg.
It's perfect, and I certainly could not have said it any better, Jose. Thank you for the kind words. It's been wonderful to have everyone here tonight talking about. I really do see a lot of this as the future of respiratory care. So thank you, everyone. Haley, Danny, and Donna, all three coming together to speak on this for the Society of Critical Care Medicine. And Jose, if you want to say a few more words to close it out tonight.
Okay. Well, thank you, everybody. Muchas gracias. Este evento se va a seguir cumpliendo cada año. Siempre contarán con el apoyo de SCCM. Y como saben, tenemos un grupo de expertos bastante grande y creo que hemos representado aquí a muchas especialidades, a todos los géneros y, por supuesto, a todos los grados de experiencias. Muchísimas gracias.